Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Joining me as we cut through the fog that exists at the leading edge of healthcare technology. My guest today is a friend. I've talked to her a few times and always like to hear her thoughts and opinions. Lisa Bari, who's the CEO of Civitas Networks for Health. Civitas is a national collaborative of member organizations that really work together to use healthcare information exchange, healthcare data, and really multi-stakeholder, cross-sector approaches to improve health. Lisa, thanks for joining me on this episode of the Tate Chronicles.
Thanks for having me again, Jim. Great to talk to you.
Yeah, I feel the same way, Lisa. Now, one thing I just want to touch on a little bit. Of course, we're going to go into the background of Civitas Networks and why it was formed, things like that. But, the word Civitas, I looked it up, and it kind of harkens back to the days of the Roman Empire as to who was a citizenship. So is that intentional naming of the organization?
More the community meaning of the word versus citizen necessarily. So we're really thinking of community networks for health, and they can be networks that are, actual telecommunications networks or networks of people and organizations. So we think of it that way. Civitas, as you know, is just a membership organization, a group, a collaborative, and then many of our members themselves run various types of networks.
Well, I believe you're probably third year. Who came together to create this, and what's the demographic of the members?
Yeah, so we are coming up here on our third anniversary as Civitas, and we were created in October of 2021, bringing together two leading member organizations in the space. We brought together the Strategic Health Information Exchange Collaborative, or SHEIC, and the Network for Regional Healthcare Improvement, or ENRI, and we created a new organization together called Civitas Networks for Health. And we didn't just smush the members together, we really created a new type of organization with a much broader mission and goals of really connecting those folks who have data, have networks, and those who are actually doing and working on improving health and quality in this country.
So it's more than just interoperability. That sounds like it's one tower, but the other one is maybe the, correct me if I'm wrong, Lisa, but, appropriate use of technology and data.
Exactly. What are you moving all that data around for? What's the purpose? We don't just move data for fun. We do it because we're trying to, improve the care delivery really at that point of care, trying to make sure that clinicians and physicians and others involved in care delivery have what they need to make the best decisions on behalf of patients, so that patients themselves have data that they need, really so that public health has data they need, so that health insurance payers, government organizations, all of the above. Why are we moving data? It's because we want to improve health. How are we improving health? Hopefully with the best data and information we can find.
The whole concept of it's one thing to have technology, but if around data, but if it's not used appropriatly, it doesn't really help things. And I think a glaring example of this was we have all these certified EHRs that can document immunizations and flu shots and all kind of things like that, and they can be reported to registries and organizations like that. But during the peak of the COVID crisis, there was no centralized place where the government, during that unbelievable once-in-a-lifetime pandemic, could know either who had tested positive for COVID or who had received, the immunization shots for COVID. Completely unknown.
Well,
Yeah.
From your lips to God's ears, if that's a once in a lifetime situation, I certainly hope so. But I'm worried it's not going to be, and that's because of the state of our public health system in this country and also across the world. And in particular, we look at the data issues. There are so many, and there are so many barriers. And one of the really critical things that many Civitas members work on is connecting their local and their state public health agencies, to data that they need. So that's something that sort of connects them across the board. I can give you a little bit more as well, Jim, on who Civitas members are today, which might also help kind of answering that question. Mm-hmm. So we've got the quality improvement organizations. These are these organizations that have grown out of now many years of really data-driven quality improvement work in America, whether it's for Medicare or for Medicaid or for other local programs. They're doing this important work of trying to understand, what quality looks like in healthcare delivery, and also then help those healthcare organizations who are working on care delivery to deliver higher quality care. And they're doing that using data. So there's the QIOs. There are these organizations we call sort of regional health improvement collaboratives. They are often sort of multi-stakeholder, multi-community partner collaboratives. They might represent employer coalitions, might represent local public health, workforce, and they're working on things with the community to improve community health. Then we have the nation's regional and statewide health information exchanges, which you know about. Nearly all of those are Civitas members today. We also have a number of health data organizations like all payer claims databases who are really doing that work looking at overarching cost and quality in a particular region or state. There's a really interesting history there and hopeful growth of more all payer claims databases to better understand what things actually look like across an entire state or an entire region. And then we have a couple of other data collaboratives, other associations with similar missions as ours who want to be in partnership with us as we work on achieving our goals together. And then we also have these strategic business and technology members who are supporting the work of all the previous organizations I mentioned. So that's who we are today. We're about 175 organizational members across the country. We've grown quite a bit.
Well, let me give you a scenario, and which I think may be a reason for organizations like Civitas to exist. You tell me. So as we move forward in the exchange of healthcare data and best use cases for exchanging that data, as developments take place, gaps open up. So probably, or whether we call it gaps or opportunities. So in the last 2 to 3 years, AI has infiltrated every level of healthcare data exchange. And point of care of patients. I mean, it's just all over the place. So I'm sure that, and even in terms of certification of electronic health records, there's all kind of requirements around AI use for clinical decision support, things like that. So it seems like there has to be some place for these different stakeholders to exchange information, or at least be on the same page about how to handle these new things like AI.
Yeah, I mean, we are, as you might imagine, we have not been able to avoid the growth in AI discussion in the landscape, and also understanding how it fits into the story. I think the first and most important thing to say is that the proliferation and the further development of AI in healthcare, or health AI, is very complex and very risky. And one of the reasons it's so risky is because, of course, the potential for bias that could harm clinical outcomes, could harm actual patients. And one of the things that goes into harming patients around data in general is the siloing of data and the lack of available data to inform patient care. So if it's already a risk for patient care when, let's say, a patient shows up and their data aren't available, we don't know all of their, medications they're taking, we don't understand what other conditions they might have. If there's already a risk there, just with regular old clinical care, now add AI algorithms. As you know, AI algorithms need data to be trained on. And if the data that they have is not complete or has inherent biases, as every data set has, you really have a potential for a risky situation that could harm patient care and harm any efforts around health equity or caring for people who are disadvantaged in any way in our society. So we are really concerned about this, as are many of our members, and they're also starting to get involved. Some of them are developing policies around the use of AI in their data. Some of them are working on, plans to help support academic efforts around, proving out how to train these algorithms in a safe way. For example, Civitas itself, we actually have an article coming out soon with some of our partners at the Ellison Institute and others, in the New England Journal of Medicine AI journal, which I wish we had it today, but it has not been published yet. It's coming out really soon, hopefully before our conference in October. And then, we also are staying abreast of the various efforts like CHAI, the Coalition for Health AI, that are trying to bring together different stakeholders to work on these issues. It's a big topic, and we're really concerned about the participation, the engagement of our members in supporting the development of this work, because we know so much about data bias.
That is, it's fascinating to me. I do a lot of work in the certification world of EHRs and EHR modules. The issue of AI decision support intervention, as they call it, if a vendor distributes their EHR with AI decision support algorithms, they have to meet a lot of standards and requirements. But if the provider chooses to use a third party out in the wild, there are zero standards. So I don't know, you never want to shackle providers. But there's got to be transparency. And so I think it's going to be organizations like Civitas that bring a lot of these issues to the surface.
I think that's right. I also think that, now that we're coming out of this initial sort of bubble of AI and bubble of health AI, people are like, okay, hang on a second, what is this actually doing? Here's, maybe it's not quite as amazing as we thought it was. There still are sort of powerful things that can happen with different developments of health AI. Yes. But really, when you look at what's actually going to happen, it's likely to be administrative improvements or administrative tools behind the scenes. Now, the problem is those can also still result in sort of biased outcomes, but really just taking a breath, understanding that it's less likely that these things are going to be applied in actual clinical care, with a few exceptions, and really more that they're going to be applied to administrative complexity or administrative burden. And then, okay, so now that we know that, what does that look like in terms of potential for bias?
Right, exactly. I agree totally with that. Just taking the long view of, I don't know, but interoperability, the whole concept of exchange of electronic health data got moving maybe 10 or 15 years ago. But then at first we thought, well, these health information exchanges or the regional health information organizations were going to be the silver bullet. And of course, there is no true silver bullet. but then the next phase was, well, if we can get everybody to use a EHR that could produce these CCDAs, these files that have patient clinical information, demographics, if that could be exchanged from one provider to another, that would solve the problem. But of course, that's not a silver bullet. And then the concept of, here we go, TEFCA,
Yeah.
a network of networks, which it works in ATMs and different banks all over the country. It works for the phone systems. So it sounds like it is a good idea from a technical standpoint, but there has to be that training or the proper use of TEFCA exchange data or the culture around it to trust data coming from third-party sources. And so I'm going to ask you this. It may be rhetorical or just an absolutely bad question, but in the trajectory of interoperability, where the heck are we, Lisa?
Yeah, so a great question. We are about 20 years into a lot of this work. So you mentioned, looking back in time when ONC was created, the Office of National Coordinator for Health IT, and sort of some of the EHR efforts stretching back before that, individually and in smaller areas, leading up to the things that you worked on, Jim, high tech and EHRs and meaningful use, myself as well, and where we are today. So, we're roughly about 20 years into this. I think the idea around TEFCA is not particularly new. In fact, as you know, the law and the regulations around TEFCA are quite a bit older. It's taken a very long time to implement them. The problem with that is that, the market and the technology and the systems move a lot faster than the regulation. There is still some question about whether this structure, this quasi public-private partnership kind of structure of TEFCA, with the government still having a role, but also a nonprofit designated organization, Sequoia, serving as the regional coordinating entity, is the right structure for where we are today. But all of that said, I look more at what the actual outputs are, what we've actually done. And so there's a couple of different sort of surveys that show where we are on interoperability. Then there's also the reality check of you in your own life. So let's start with sort of the surveys. One of the biggest surveys around interoperability at the hospital level is the American Hospital Association's big survey, and they have an information technology supplement where they measure every year kind of the same stuff and show what progress we're making, who's actually connected, who's actually moving data in those big hospitals. And we're flat, right? We're pretty flat. If you look at the latest results from 2023, we're about 78% of these hospitals are connected to a health information exchange and actually moving data. And then it's something lower than that that's actually connected to the national networks and exchanging data. So flat is not amazing. I don't love that. And then we also have a big survey, the Health Information Organization survey that Civitas partners on with UCSF as the principal investigators, and it's also funded by ONC as well. And I'll just kind of I'm going to read you their conclusion from the latest survey, because I think it's helpful.
Please do.
Well, HIOs, that's health information organizations, health information exchanges, have decreased in number due to consolidation. They have increased in size and scale, still covering many areas of the United States. Future sustainability is more complex, with remaining HIOs reporting diverse funding streams and adopting a business model that relies less on participant fees and more on public funding. As TEFCA launches, almost 2/3 of HIOs plan to participate in TEFCA, and the majority of those that did not plan to participate in TEFCA indicated they did not know yet if they would. Et cetera, et cetera. It says policymakers should consider whether and how to ensure broad participation by HIOs to further advance nationwide health information exchange as envisioned by TEFCA. So they are making a wonderful point here. Obviously, I'm biased. We provided a lot of the support, and we connected them to our members to do this survey, which they do every year. This is truly the outcome, is that if you want TEFCA to be successful, you need broad and deep participation from across the landscape. You need HIEs, you need EHRs, you need everybody else. And yet the design was not ideal to ensure that. And we are in the process of cleaning that up and fixing that any way we can to get the broader participation needed. And it's not that easy, right? One of the issues that's really important is that, and this is what you'll hear me say a lot, healthcare is local. Health data exchange is inherently also local. There are different laws. There are different policies. There are different preferences. There are different people. And as you probably also know, Jim, it's not that easy for the federal government to preempt state laws in every situation. They exist for a reason. That's how our country is set up. That's our form of government, right? It's state. And so I think it's a federalized system. And so it's just not that trivial to just say, never mind your state laws, never mind your state networks. We're going to do a federal thing. That's just not how it can work. So we've got a lot of work to get to this vision of nationwide data exchange.
I think what I'm hearing from you, Lisa, a lot of what Civitas is doing, of course, it takes a leadership position, but also addresses challenges as they arrive, because you don't always know what they're going to be. And that actually leads me to the fact that you've got an annual conference coming up in just a little over a month in Detroit. So what's that going to be about?
Yeah. So one of the, we've got a lot of great stuff happening. So every year we have our annual conference. This year we are in October. We moved a little bit later in the year. And every year we go to a different region of the country. We have members across the entire country. So this year we're in Detroit. We've got a ton of members in what we're calling the Upper Midwest region, and they are helping us, co-host the conference. So we've got so much going on. The theme of the conference is kind of the theme of Civitas, which is, we call it the bridge between data and doing. So our members are somewhere on that bridge. They're on one side, they're on the other side, they're crossing the bridge. They are bridging data and doing. And that's what you see across all of our membership and across the agenda of the conference. So we've got some really great, we've got a great, kind of opening keynote with folks from Michigan. So we are actually having a keynote with Michigan's Lieutenant Governor Garland Gilchrist and a policy and planning director in the Department of Health and Human Services in Michigan, Nina Sassy. And they're really talking about this important work of connecting social care and healthcare delivery and healthcare data. So just kicking that off, we've got a great session that shows what this is actually looking like in the States. We've got extensive, different types of sessions, workshops on data standards, data quality, data governance, health equity, all those interoperability issues, the actual implementation, those partnerships, policy, public health, social care. This is really the place to find all of this work that's happening at the local level.
Is this just for the membership of Civitas, or can anybody register?
Oh, no. Open registration. We've got lots of folks coming, folks from the government, federal and state, members, their partners. We'll probably have more community-based organizations this time because we've really made a focus of asking our members to bring their local partners to the conference. This is this is open to the public for sure.
And is this a situation where if I'm interested in one particular aspect of all this, I can follow a track? Are there different tracks or?
So we have a couple different tracks. We've really tried this year more to sort of tag our sessions with different, elements. Like this session's going to get into data standards. This session's going to get into health equity issues. So we've got tracks, but we also have tagged them to give people an easier time to go, I'd like to pursue this area of interest.
Yeah. One thing you mentioned, health equity, just harkening back to algorithmic bias potential in AI. If somebody goes out there and grabs a bunch of healthcare data, there's a good chance that's coming from people who have been to a doctor and most of them have insurance. So there are a lot of folks who don't fall under that umbrella, or you're not building a clinical decision support rule based on, you're ignoring an entire population. So,
yeah, absolutely.
Yeah.
Yeah. Just a few other notes from the conference. We have a bunch of the typical. We actually, speaking of Health AI, we have an entire keynote panel on the governance of Health AI, which will feature Mickey Tripathi, who, as you probably know, is the National Coordinator for Health IT, but also added a few additional titles recently. He's now the Assistant Secretary for Technology Policy, and he's also the Acting Chief Artificial Intelligence Officer of the U.S. Department of Health and Human Services. So he has got a variety of new jobs, and he is going to be on the panel. We've got Dr. Craig Watkins, who is a professor at UT Austin, who focuses on this work. Grace Cordovano, who's a patient advocate in this space, and also we have someone from the Digital Medicine Society joining as well. So lots of cool stuff there. We also have Dr. Meena Seshamani, who's the director of the Center for Medicare at CMS, who's speaking in a different panel or different keynote session. And also Rosalind So, who's the director of the Indian Health Service, speaking about data modernization for the Indian Health Service. So there's a lot of great topics. Those are just the keynotes. We have so many great sessions. We've really tried to make them engaging, collaborative. There's a bunch of workshops that are not really just someone talking at you. So lots of good stuff here.
Lisa, we're almost totally out of time, but before we say goodbye, what is the best way for folks to find out more about the conference or about the Civitas mission? Just get more information. And let me mention, I think on a regular basis, there's like virtual webinars that you do.
Exactly.
Give us that information, please.
Exactly. So everything is on our website. It's civitasforhealth.org. That's CIVITAS health.org. And we do roughly quarterly, open to the public webinars called Collaboratives in Action. We have a bunch of member stuff too, but open to the public. You can check out our newsletter, which is sort of personalized to you. You can sign up for that on the website. And you can also get those virtual open to the public sessions as well. So lots of ways to engage with Civitas's work and our members, and really would just welcome folks to join us in Detroit. It's going to be a really great time, October 15th to October 17th in Detroit.
Okay. Well, totally out of time. To our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Lisa Bari, CEO of Civitas Networks for Health. Lisa, thanks for coming aboard today.
Thanks for having me, Jim.
You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.